Ladies and gentlemen, thank you very much for this opportunity to present you the results of our study. My name is Kirill Lobastov and I'm from Moscow, and I have nothing to disclose according to this presentation. We know that COVID-19 is associated with a high risk of thrombosis, arterial and venous, and the most comprehensive meta-analysis that was published in CHEST in 2021 suggested the incidence of thrombosis about 17%. But however, on the other side, such patients have a high risk of bleeding, and it was estimated as about 8%. And most of these patients are receiving the increased therapeutic doses of anticoagulation. And we know from the recent randomized clinical trials that it's not always effective and safe in such a group of patients, particularly those who are admitted in the intensive care unit. They have no any benefits from the increased dose of anticoagulation, and those who are admitted to the floor, they have some little bit benefits of the increased dose of anticoagulation. However, the risk of bleeding always increase. That's why it's very important to assess the individual risk of venous thromboembolism in such a kind of patients. And previously we have published our data on the validation of the Caprini score in patients with COVID-19, and we evaluated the different versions of the Caprini score, the original taking into account the elevated dimer, and the modified Caprini score taking into account the specific COVID-19 points. And we found that all of these versions have a high predictability for the symptomatic venous thromboembolism that occurred within the inpatient period treatment and after discharge. And the highest predictability were found for the original Caprini score, which took in account all possible risk factors because it was assessed at discharge or at the moment of patient death. But however, for today we have a new data that the Padua score and Improve DD score is also predictable for the symptomatic venous thromboembolism in such patients. And that's why we decided to compare the predictability of the Caprini score and the Padua score and the Improve DD score in our cohort of the patients. Though it was the same cohort of 168 patients with a confirmed COVID-19 who were admitted to our institution in May 2020, and it was not very severe population because the admission to the intensive care unit required only 17% of patients, only 5% required mechanical ventilation, and only 5% of them died. And we used the data on Caprini score from our previous analysis, and additionally we extracted from the electronic medical records the data that was used to evaluate the Padua score and Improve DD score. So these scores were evaluated retrospectively from the electronic medical records. And most of our patients received the intermediate doses of the enoxaparin within the inpatient period of treatment, and some of them continued the anticoagulation after discharge. And we evaluated the incidence of symptomatic venous thromboembolism within the 6 months of follow-up. So the venous thromboembolism occurred in 12 patients, and it was catheter-related vein thrombosis of upper limbs, isolated lower limb DVT, and one case occurred after discharge, combination of lower limb DVT and PE, and isolated PE in 5 patients. We observed no major bleeding in our patients, but however 3 cases of clinically relevant non-major bleeding were found, and one of them occurred after discharge in patient who continued the pharmacological prophylaxis. So as you can see, the evaluated Caprini score, Padua score, and Improve DD score ranged in a wide range, and it was from 2 to 15 for the Caprini score, from 3 to 10 for the Padua score, and from 1 to 8 to the Improve DD score. And here you can find the mean value of the scores. So you can see the all risk factors which are taken into account when we evaluate the Caprini score, Padua score, and Improve DD score. And of course, the Caprini score contains the most long list of the risk factors, but however, most of these risk factors were not found in our COVID-19 patients. And here you can find only those risk factors that were observed, and according to the Caprini score, all the patients had the serious lung disease and the bed rest. Most of them were obese, and they had an advanced age according to the Caprini score. According to the Padua score, all of them had reduced mobility and acute infection, and most of them were obese. And according to the Improved DD score, it is a similar to the Padua score, but however also the elevated D-dimer is taken in account in this case, and the elevation over the 2 upper limit of normal was found only in 15% of our patients. Here you can find the correlation between the score and the incidence of the symptomatic venous thromboembolism, and it was a significant correlation with the all scores, but however the strength of this correlation was from moderate to high. It's assessed by the Kramers. Here you can find how many patients were classified to be in the high-risk group according to the Caprini score. It is 5 scores and more, and 65% of patients had this score and were classified as a high risk, and the VTE developed in 9% of them. According to the Padua score, the high-risk group is 4 scores and more, and 99%, particularly all patients, were classified as having the high risk according to the Padua score, and the risk of VTE was 7.2%. And according to the Improve DD score, the high-risk group is 4 and more scores, and only 13% of all patients were classified as having the high risk, and the incidence of the VTE was the highest in this subgroup. Here we compared how many patients developed VTE if they were classified according to the standard thresholds to the high-risk group of the Caprini score, Padua score, and the Improve DD score. As you can see, only according to the Improve DD score, this classification was correct, and the patients who were classified at the high-risk group, they had the significantly increased incidence of the symptomatic VTE compared to those who were classified to the non-high-risk group. And then we calculated the predictability of the all possible scores according to the analysis of the ROC curves and area under the ROC curves. As you can see, there was no difference between the Caprini score and the Improve DD score, and it was a high predictability for the symptomatic VTE. However, the predictability for the Padua score was the lowest, and it was significantly lower in comparison with the Caprini score, but not in comparison with the Improve DD score. And here you can find the final results. We tried to find out the threshold of the Caprini score, Padua score, and Improve DD score, which with the combination of high sensitivity and specificity predict the symptomatic venous thromboembolism. And for the Caprini score, it was more than 10 scores. For the Padua score, it was more than 6 scores, and for the Improve DD scores, it is more than 2 scores. So, ladies and gentlemen, we were able to conclude that Caprini and Improve DD scores can equally predict symptomatic VTE in COVID-19 patients. The standard thresholds for the high-risk group are not accurate for COVID-19 patients undergoing pharmacological prophylaxis, and revised thresholds are needed to predict VTE in this group of patients. Thank you very much for your attention.